We invite Dr. Ramesh Chandrasekharan, Head Diabetes Department VHS and Vice Chairman of TAG VHS DRC, to speak on establishing a research unit for increasing the interval period in renal dialysis and improving its cost effectiveness.
Professor B.M. Hegde, Professor C.V. Krishnaswamy, distinguished colleagues, doctors, ladies and gentlemen. It gives me great pleasure to talk about, we have just seen how alternate systems of medicine, we have just seen how other modalities or alternate modes of treatment can help people get better, and also we are here to see how this in the future, how these modalities in the future can help the quality of life of people. For example, in this case, we're talking about chronic kidney disease and people requiring dialysis. If these modalities, in one way or the other, can improve the quality of life and also bring the cost down by some extent. For example, people requiring dialysis who are in their end stage of renal disease, they require less and less frequent dialysis. It cuts down the cost and also the quality of life. So let's see, I will have a little introduction about chronic kidney disease. Some of these are technical, so I'll just skip through as fast as I can, and then come to cases where we have seen some good results using these methods. First slide. So we have talked about diabetes and how much damage it can do to the blood vessels. One such complication, which is a small blood vessel complication or microvascular complication of diabetes, is diabetic nephropathy. It's about 30%, 1 in 3 of chronic renal failure, that is people requiring assistance because of kidney problems, are due to diabetic nephropathy. Nonetheless, it's not attention towards diabetic nephropathy is not directed until the patient has progressed towards the stage of renal failure. So nephropathy due to diabetes can be diagnosed very easily and can be also prevented. So all long-standing diabetics will not have diabetic nephropathy, and all long-standing uncontrolled diabetics probably will have more chance of having nephropathy. So to diagnose a diabetic has developed diabetic nephropathy, fundal examination, looking into the eye is also essential. Well, the same thing, microvascular, that is small vessel disease, macrovascular, and retinopathy, it's a similar principle involved, damaging the blood vessels. Next slide. So in a recent study, it was observed that Asian subjects have significantly high prevalence of diabetic end-stage renal disease. In type 2 diabetes, many patients may not reach end-stage renal disease due to premature death from cardiovascular disease. What is the reason behind? The pathophysiology of diabetic nephropathy is multifactorial, many factors, and genetic susceptibility, that is you're prone because of your genes, has also been proposed to be an important fact development of progression of diabetic nephropathy. So two major causes has been implicated in the development of diabetic nephropathy. One is metabolic and hemodynamic. So there are some changes in the kidney which takes place because of these two factors, and that over time leads to kidney damage. So most common causes, we know diabetes is a major cause, blood pressure and glomerulonephritis. That's a problem within the kidney. Together these cause almost 75% of all adult cases of chronic kidney disease. So there are diseases depending on which part of the kidney is affected. One could involve the blood vessels, the other one involving the glomeruli, and there are some secondary causes because of diabetes and something called systemic lupus erythematosus. Yeah, tubulointerstitial, again there's another disease called polycystic kidney disease. Drug and chronic toxin induced, that is very important here because a lot of times you have problems in the kidney because of indiscriminate use of certain medications over time and without any other cause being there. it can be blamed as because of diabetes or because of other reasons. But one important reason we'll have to know is indiscriminate use of drugs. Right. So how do you diagnose? There are many ways. It's early. It's important to diagnose chronic disease early. Many chronic kidney injury, or CKI it's called, patients, previous renal disease or other underlying diseases are already known. For example, a number of patients, have long-standing diabetes, which is uncontrolled, then we know it's because of diabetes. And a small number of patients, we don't know the cause. In these patients, we look back at the records and we find that there is a probable cause for that. It is also important to know somebody who has an acute injury, that's because of a recent event, then the prognosis or the chance of treating the person with that injury is much higher. And these are patients who will not go on for dialysis or prolonged treatment. And you have to differentiate that from people who had kidney disease because long-standing diabetes, other causes, where there is more chance of people going in for long-standing treatment. Next. There are so many tests available to diagnose the problem early. One such is some of these scans called the MAG3 scans, and the other things we'll be following. Next slide. Right. What about genetics? Familial factors may play a role in the development of nephropathy. Certain groups, ethnic groups for instance, particularly American blacks, Hispanics, Native Americans, may be particularly predisposed to renal disease as a complication of diabetes. For example, it's found that proteinuria, that is protein in the urine, was present in about 50% and microalbuminuria in 26.7% of siblings, that is brothers and sisters of people with diabetes, of probans with diabetic nephropathy, for example. Next. What about registries? What is the disease burden? What end-stage renal disease in India? But we don't have reliable statistics here, but what you can say is the incidence of ESRD is supposed to be probably likely to be higher than what is reported from the developed world with chronic glomerulonephritis. It's one of the conditions for chronic kidney disease, the most common cause, accounting for more than 1/3 of patients with diabetic nephropathy, and 1/4, diabetes accounts for almost 1/4 of all the problems in India. And what we found that was, patients are generally younger. Mean age is about 42 years at the time of detection. And 2/3 first see a nephrologist after they almost reach the end stage. So what has happened is the treatment of end stage disease is a low priority for the cash-strapped public hospitals. And in the absence of health insurance, the plans, less than 10% of almost all patients receive any kind of replacement therapy. The vast majority of patients who start dialysis die or stop treatment because of the cost constraints within the first 3 months, and less than 2% are started on peritoneal dialysis. Although renal transplantation is the cheapest option, only about 5% of patients with end-stage disease are having a transplant. Next. So what about donor transplants? I mean, there is a Transplant Act in India which probably, because of the indiscriminate use of donors from unrelated donors, there is a strict transplant regulation here. There are a lot of drugs which are being used when you are on a transplant, and not without side effects. A lot of these things are really not possible for many people because of the cost and other factors. Next one. So magnitude, we talked about the incidence and prevalence of diabetes has increased, so is the problem with the kidney. It's estimated that over 40% of the patients developing end-stage disease have diabetes as a cause in India. And you should also know that people with type 1 diabetes and type 2 diabetes, type 1 diabetes, we know that the kidney problems start after a certain fixed time of diagnosis, but in type 2, they may already present at the time with chronic kidney disease. Next one. So primary prevention nephropathy is probably possible with rigorous glucose and blood pressure control, and screening for diabetic disease will fall within the scope of secondary prevention. And finding protein in the urine as early, starting screening for microalbuminuria, is the first step in detecting chronic kidney disease. Like I said, there are also other factors like infection, stress, and other things which we need to explore before we make a diagnosis. Next one. Well, this is about screening. Yeah, microalbuminuria. Next one. Urinary albumin excretion rate, and also we'll also check the serum creatinine, fundus examination to make sure diabetes is the cause for the nephropathy. The same thing, what happens in stages, what is your blood pressure and glomerular filtration rate. Next. So we talked about drugs, sugar control, dietary protein intake, and of course smoking. What do we do to manage diabetic nephropathy? The other thing I mentioned about is using discriminate drugs or correct drugs, not indiscriminate drugs, which can in fact be counterproductive. Next. Yeah. Among those who should be screened are subjects with hypertension, history of cardiovascular disease, those with diabetes, obesity, those aged greater than 60 years, subjects with and other racial groups who have a higher predisposition to kidney disease, and those who have a history of renal disease in the past, and also subjects who have kidney disease, relatives who have kidney disease requiring dialysis. Next. Yeah, we mentioned about medications. There are a whole list of them which we used in the early stage of kidney disease to prevent further progression. Next. While renal replacement therapies can maintain patients indefinitely and prolong life, the quality is severely affected, and renal transplantation increases the survival, but when compared to other therapy options. But of course, there are other disadvantages like the medications used, the cost, and mortality due to the complications of surgery. Next slide. So what are the other systems we have which might complement or probably use it in people who conventional allopathy or other treatments have failed? We have heard about the talk earlier, Ayurveda, homeopathy, Siddha, and we've heard a lot about pulse, electromagnetic field therapy, and dam therapy, which you will be hearing in course of time. Next. So this is the first case. We thought we'll present two cases who had we tried these the complementary systems of medicines. One is such case where Ayurveda was tried, and 35-year-old chartered accountant working in the Middle East was diagnosed in August 2010 as a case of glomerular nephritis and renal failure. And he had hypertension and type 2 diabetes. He sought an opinion from a kidney specialist who told him that this gradually progressive condition which needed control of diabetes and hypertension, and eventually he might require dialysis and renal transplantation within 2 years of life. So he was advised certain medications for his diabetes control and a combination of medicines for his blood pressure. He was extremely frightened, and he tried, let's say we'll try the alternate therapy to see how he can progress. So he went to seek treatment from the senior most Pandit K. Sharma from the Ayurvedic Vaidya Ratna, and he was former principal of Venkatramana College of Ayurveda. So he's been following his Ayurvedic therapy ever since. We will acknowledge his presence here. Professor Sharma. So he's been reporting to us every 3 months after having his advice, and clinically he's improved very significantly. His blood pressure, which was initially in 2010 was 180 on 100, is about 150/80 now in November, and it's probably even better now. We don't have the records recorded here. Blood sugars were absolutely normal, and without any medications, his average of HbA1c was 5.8. So he was measured with his serial urea and creatinine values. We'll see in the chart. And the urine protein, which I talked about, has come down from 3.49 grams in August 2010 to 682 in 211 and 2.1 grams right now, stable at that in October. Is presently asymptomatic and is working overtime without much fatigue, which he had earlier. Well, this is the graph of the creatinine values, which is the slight increase is because he went on a trip, on a long-standing walking trip to Tirupati, and he's back, and hopefully now his creatinine has come down, and I think his recent record is about 2 or something like that. So that is the urea. Next slide. And we go to the next case. This is in a patient. We used the pulsed magnetic electric field therapy along with the other modality, what we call is dynamic acupuncture mediated metaphysical therapy. In a gentleman who was 53 years old, a businessman who presented to the clinic in 2010, severe anasarca. What it means is there's full swelling in the body due to severe heart failure or LV dysfunction, as we call. And the cardiac echo at the time reported 22.2%. He had a fast heart rate and he had a dilated heart, and those are all the recordings from the echo. Severe LV dysfunction, and he also had some pleural effusion. So he was admitted to a private hospital at that time. He was initially treated in the ICU and stabilized, and the opinion of the cardiologist was sought at that time. So he was readmitted in ICU in November 2010 again with fatigue and general tiredness and fatigue. That time, he also happened to have some problem with the kidney, an infection in the kidney, which renal sepsis, and his creatinine, which is an index of renal function, was 5.7, and urea about 228. So at that time, he sought a nephrologist opinion for this problem, and he was treated with antibiotic and other supportive measures, along with the medicines for his cardiac condition and diabetes. He was readmitted again to a private hospital with hematuria. At that time, he had a CT of the kidney, urine, and bladder, bladder, and which showed some changes, what we call as emphysematous pyelonephritis. So a stent was inserted, and he improved clinically after 1 and 1.5 months with other things. He was started on pulse therapy at that time for at least 1 year. I mean, he was been on that therapy since that time, and his ejection fraction seemed to improve from 22% to 45%. He became less breathless, and also what was important was when he had the DAM therapy at that time, his renal parameters improved from November 2012 to he resumed his business. We can see the graph now, the next slide. See how his creatinine shot up. That was at the time of infection, and now it's steadily holding on without any other invasive treatment. Urea, a similar picture. So these are 2 examples. We can see how these modalities can help us, not to say that one is better than the other. We can try out these along with the other methods to see if can help people with their problems and quality of life. Thank you.
Thank you, Dr. Ramesh. We call on Dr. C.V. Krishnaswamy to introduce the metaphysical energy medicine, which will be followed by a demonstration of cases by Mr. Rajan Iyer. And we have lunch for you upstairs after that.
Bad pennies return. I have a very interesting task now of introducing a very unusual gentleman, an unusual person, and who practices an unusual healing technique. This is something which has fascinated me from the day I saw his work. I hope that you will also find him interesting enough to be unbiased and give your verdict after seeing what he has to say and what he can do. These are the 2 requests that I make. Don't get biased and have fixed mindset. medical healing takes all sorts of ways to improve the health of individual. When our own people are not well, we all pray, and that gives energy. That definitely we believe that prayer also helps, and it has been proven in heart cases that those who have prayed recover than those who have not been prayed for. This Professor Hegde showed way back with his chief Bernard Lowen in Massachusetts General Hospital in Harvard, in Boston. So this, with these brief words, I would like to start my introduction of Mr. Rajan Iyer, who is a remarkable man with an energy therapy healing technique using small needles, which are not the actual traditional acupuncture needles, but small gadgets through which he says he is able to transfer the macrocosmic energy. As Professor Hegde's talk, if you had learned carefully, that the human genome is made up of several trillion germs. We are all metagenomic people. It's not the 25,000 genes of ours which constitute us. There is a whole lot of external influence in our body, and so we are all the sons and children of our environment. So if we can get the environment to correct us in various ways, the principal elements of the environment certainly will help us if we know how to utilize it. Now this man has trained to utilize this, and some of the work he has done in the last 8 months in our center has shown us that there has been a subtle understanding of this system of, I won't call medicine, the system of healing of human ill health. Okay? Now.
Prithvi Shanti Antariksham Shantirjao Shantirapashtantirosadastantirvanaspatastantirvishme Devantirvarve Devashantishantishantishantivih Adhistantivihkarvasantivihtamadamoham Yadiha ghoram yadiha kruram yadiha pavam tatshantam tatshivam sarva deva samaskuraha.
The baseline, the bottom line of the whole thing is Shanti, Shanti, Shanti. That we want peace, we want health. Sarve Jana Sukhino Bhavantu is the chant that we usually do, and we pray for everybody's health. This prayer, which comes from the Atharvana Veda, is a very, very interesting sloka. Atharvana Veda went into disrepute, and probably none of us know the real meaning of Atharvana Veda in today's world, because we are all engaged in things which are so commercial that whatever is non-commercial is not thought fit enough to pursue. And also the foreign invasion took away all these things, confining it to inscriptions that are available only in certain parts of India and a few families who are adapted it. And also there is another portion of Atharvana Veda which had magic and tantras inserted into it, and people misused it and exploited it. But with the advent of certain enlightened people like Mata Amritananda Mayi, who a couple of months ago released a volume of a text of Chaturveda Samhita in Kollam. Mata Amritananda Mayi, when she released it, everybody knew Mata Ananda Mayi and how much of an energy healer she is. I don't need to tell that. And there it is written that it is a part of Rig Veda that was taken away for day-to-day health and day-to-day living and warding off all minor illnesses. Now today in the evening we are going to listen to Girija, Dr. Girija, who is here, PLT Girija, who is an Ayurvedic exponent, and she is going to say why we should not use Ayurveda as a first line therapy so that we can cut so many medications. As Ramesh just now pointed out, painkillers are the real killers, not diabetes. You take so many painkillers, insidiously, the